everyone. So today I'm going to tell you about the Monarch Initiative, but because I'm so inspired by Michelle's talk and also the panel, I wanted to just briefly mention a company that, as a public benefit company, that we co-founded because of my just level of anger and frustration about not having genomic healthcare available to everyone in this day and age. And so this public benefit company, it's called Alamaya Health, is focused on bringing that genomic healthcare to all the sort of community hospitals and places around the world that really lack that. The technology is ready, the policies aren't. So my plea to you all is to urge, whether it's us or some other organization, to really bring those kinds of newborn screening programs to everyone. It can't only be at fancy pants academic medical centers that for the people that have access to that. So I just wanted to start with that. All right, so let's see, how do I move things along here? Here we go. So the Monarch Initiative was created about 15 years ago when we figured out that we could use model organism data to help diagnose rare disease patients. And at the time, this was a rather radical idea. This sort of has become the sort of de facto standard now that we actually, and in our diagnostic efforts, use to treat the patients as biological subjects, because fundamentally diagnosing a disease is a biological problem. And unfortunately, our healthcare systems are not designed to treat patients as biological subjects, but rather document clinical encounters and are used for billing purposes. And so one of the primary goals of the Monarch Initiative is to build data systems to help the electronic health record and clinical encounter and diagnostic systems really leverage a much broader wealth of data. And so this is really, because I'm here for the Health Equity Forum, it's really meant to be somewhat educational in helping everyone here, and there are people from all different backgrounds here, to understand how we can work together to make the world contribute to our collective knowledge about rare and genetic diseases, so that that knowledge can be used for everyone the next time the next person needs a diagnosis. I'm a big open science enthusiast, obviously, according to my title. These slides are available, and there's a lot of materials in here that I'm going to gloss over. For those of you who are interested, you can follow up later and look at the slides. So they're posted there at that bit.ly/monarch-rare2024. So first of all, I think we all know that why we're all here today is 1 in 10 Americans are affected by rare diseases, and as many as 400 million globally. And the patient's characteristics are akin to the variation in zebra stripes. So zebra is often used as an icon for rare diseases. And if you were at yesterday's conversation about AI, we talked about my dream of having a zebra button in the electronic health record system, so that general practice clinicians, similar to my public benefit corporation, can actually have access to that world's knowledge when they need it. General practitioners are not trained to be, expert diagnosticians of rare diseases, but the information is there and should be there at their fingertips. We had a big community effort that included NIH and many other organizations several years ago to write a paper about open science and rare diseases, and I would urge you all to take a look at that paper. There's a lot of really wonderful ideas for how to develop communities and collaborations in that paper. So I wanted to talk a little bit about the fact that this number of 7,000 rare diseases has been quoted from the Orphan Drug Act back in the 1980s, and we hadn't updated that number in a very, very long time. It's obviously a very wrong number. Why do we keep quoting that number? And so we sought out to try to reconcile rare disease knowledge around the world, to try to understand, not so that we could actually count the number of diseases, but so that we could actually inventory those rare disease definitions so that they could be made available to diagnostic tools for everyone to have access to. So the problem that we have in medicine in general is that mostly the field of biomedicine is over there on the left. We have notes, we have flat lists like problem lists, your signs and symptoms, we have ICD codes. And if we really want to think about treating the patient as a biological subject, we need to be over there on the right. We need to be able to multiply classify things and link things and use more modern technologies Clinical informatics is probably, I don't know, we could argue about this, maybe 20 years behind bioinformatics. We are not using the most modern technologies in clinical informatics that we could be to help diagnose patients and help reveal mechanisms that would help us find those treatments. So this is a paper that we wrote together with the National Center for Advancing Translational Science and several other organizations, Sanford Health, who I know is here, and where we evaluated the patient trajectories for 14 more common rare diseases, just to look across the healthcare systems to understand the variability that we see for those 14 rare diseases. No one's really ever done this before at this kind of scale across multiple systems, and it's very challenging because the data that lives in different electronic health record systems is different in the different systems. And what we found was actually, not only was it interesting to evaluate the trajectories and the sort of spectrum that we see for patients with the same diagnosis when they get diagnosed early versus late, but when we looked at the prevalence across these different healthcare systems, we found that it varied enormously. And it also didn't match what was published in the literature. So fundamentally, and this is for diseases that actually have an ICD code. So ICD is the International Classification of Diseases, and fundamentally lacks most of the rare diseases. And so I'm going to talk about some things that we're doing to try to improve that so that every rare disease group doesn't have to go begging the WHO for their rare disease to get an ICD code. But this is the landscape that we live in. We don't even know how many rare disease patients there are of any given rare disease out there, to the points made earlier, and to Danny, and we need to be able to understand what is the nature of rare disease population within the United States and across the world. So I don't have time to talk about all of the nuances of how this came to be, but over the last 5 years, there's been a global community effort to reconcile the world's rare disease knowledge. And there are dozens and dozens of sources of information, including many of the patient advocacy groups and foundations that capture details about the genetics, the phenotypic features, the treatments, that can really help other people in the community to help diagnose patients with those rare diseases. But reconciling that knowledge has been a 5-year effort. And so we named this ontology. It's an ontology, so it's a multiple inheritance classification called MONDO, which means for the world. And so what I want to just highlight here is just, you can see in the center with all the colored boxes, these are all identifiers that represent one disease knowledge source's information about that disease. And we have computationally determined that these terms, this bit of information from each of these sources is equivalent. And all of the lines that you see squiggling to the left and to the right have to do with the relationships that those knowledge sources have to other labels that are used for that disease and to other sources. And so you can see it's a big spaghetti ball. So many sources have the same labels for diseases that are not the same, and many sources have different labels for diseases that are the same. How are we going to deliver diagnostic tools that work, that actually represent all the disease knowledge, if we can't even come up with a way of understanding which diseases are the same across these different systems? So this is what the MONDO effort has tried to attempt, and we have been working with all of these sources directly to try to improve them upstream as well, so that the things that we're learning in this process can be fed back to them in their communities where that information is used. So one thing that came out of this is we were actually able to count the number of rare diseases. So this is just for simplicity, looking at only 5 sources of knowledge. The National Cancer Institute's thesaurus, the disease ontology, which is used by the model organism community, the GARD and CATS effort, which is focused for patients, Orphanet, which is a European resource, and the Online Mendelian Inheritance in Man, which is a US resource that's been around for more than 50 years. And what we found when we reconciled all this knowledge from all these different sources was that many diseases are actually in only one source, which really tells us that MONDO is really important. It's really important to reconcile this knowledge. The number is, thousands and thousands of diseases are only in one source. Shockingly, only 333 disease concepts were found across these 5 sources used for rare disease diagnostics. mind you. And we wonder why we aren't doing a very good job of diagnosing rare diseases. So figuring out how to share this. And so when we did this, we were able to count. And the number was, well, it's actually probably around 12,000. But we got, at the time when we first did this, and this was several years ago now, we counted 10,577 rare diseases. So, and this is where all of the kudos come, because there's a lot of people in this room that helped make this possible. We got the NIH, the FDA to agree, together with Global Genes, EveryLife, NORD, Sanford, and many other organizations, to stop saying 7,000 rare diseases and start saying over 10,000, because everybody could agree, we absolutely know there's more than 10,000 rare diseases. And so the point isn't how many there are many more than that. There are many undiagnosed cases, there are many N's of ones. But the fact is we can't collectively advocate for policy changes, for insurance changes, for all the changes that are needed to really support the 10% of the population that has a rare diseases if we don't even have a more accurate estimate. And so if rare disease patients, they won't count if we can't actually count the number of rare diseases and understand the particulars of their diagnosis and their care. So kudos to everyone in that box on the left for making that happen. Okay, so we must get all of these rare disease definitions into the electronic health record, but we have to start where we are. So right now, as I said before, there's very many rare diseases that do not have an ICD code. Those are all, as far as we can tell, and now inventoried in Mondo. It's imperfect, but it's getting better every day. And so we've been working with the WHO to figure out how do we get those Mondo codes and terms and cross-references that sort of reconcile all these knowledge sources into electronic health record systems by building that into the ICD-11 release process. So it's a long way off because ICD-11 is not yet in place here in the United States, and it won't be for some time in many other parts of the world. But we're starting to work on how do we do this, because the rare disease genetics knowledge changes, daily, whereas ICD-10 is only released a couple times a year. And so we need to have that knowledge be much more rapidly updated. And so we're working out ways that we might be able to do that with them. We're also working with the Intelligent Medical Objects company to deliver Mondo directly into electronic health record systems. And so that's another way that we can start getting actual rare disease codes into electronic health records so we can better address this issue of understanding incidence and prevalence, and therefore understanding the sort of community level impacts of specific rare diseases. So I wanted to introduce the human phenotype ontology. This is another Monarch product. And this is an ontology or a terminology that characterizes phenotypic abnormalities, so your signs and symptoms. And it treats the patient as a biological subject. So for example, cafe au lait spots, those are not something that a clinician would manage manage care for in a clinical setting, so it tends not to be something that's coded in a current electronic health record system. But these kinds of features are absolutely critical in helping us diagnose rare disease patients. And so currently what we do is we have different systems and tools outside the electronic health record to capture this information that are the phenotypic information about each individual patient that we can then use to compare against other patients and to compare against our known rare diseases that are inventoried with the Mondo terminology. And we have translated this into many, many languages so that it's available around the world, and we have many contributors. It's amazing to see it's in Chinese and Japanese and all these amazing languages that we just have clinician experts who have different ways of representing these things. And so it's been a real community effort to do that over many years now. So I wanted to show you how this works and this is where for the patients and patient advocacy groups in the audience, where it's critically important that you help develop and use these standards in documenting the signs and symptoms, because it really helps not only get more patients with your rare disease of interest diagnosed, but it also helps us build better tools for many other rare diseases and help build those differential diagnostics. And so this is a real example from a colleague's clinic of mine, where we had a 3-year-old girl and a 14-year-old boy come into the same clinic within several weeks of each other. They did, whole exome sequencing and were unable to diagnose these two patients until they actually did the human phenotype ontology-based phenotyping, where you can see on the left in the green, we have, again, these really like specific phenotypic features that would not normally be found in an electronic health record, like cone-shaped epiphysis of the phalanges of the hand is, again, not something that's a clinical condition that would be managed for, or having short toes or long toes. And you can see there's some opposite phenotypes here as well. So in the middle is the Monarch gold standard profile that we've curated. So this is our reference standard for Wiedemann-Steiner syndrome. And we can see that not all the phenotypes are present. Some of them are opposite, some of them are more general or more specific. But our algorithms allow us to make that comparison and help use this phenotype data together with the genomic data to diagnose these patients. And so these two patients were diagnosed following this phenotype first based approach together with the whole exome data as having two different variants in the same gene, KMT2A. And so it's important to recognize that, does this mean that these are two different subtypes of Wiedemann-Steiner syndrome? Well, that's a good question. That's a problem for Mondo, and we've been working with the ClinGen organization to help define lumping and splitting parameters for how we define new diseases. So we've also translated this into layperson. So this is the exciting thing, is that we fundamentally believe that patients and families should be collaborators in their diagnostic odyssey, to Michelle's point earlier and also on the panel. And so we translated this into layperson. And so, for example, a patient should not know what micronathia is or what mitral valve prolapse is, but you know what heart murmur is, or spider-shaped fingers or small jaws. And so if we can get patients to use the same terminology with this translation as the clinicians are using to describe these features, we can actually have a much more comprehensive representation of your phenotypic features. And some of these features are things that you don't notice in the clinical setting. So for example, if a baby doesn't have tears or if someone snores, these are not things that are necessarily observed in the clinic. And so, but they're critical for doing the clinical diagnostic. Okay, so onto the model organisms, why model organisms should matter, and why these tools, if you use them, allow us to bring in that model organism data and really leverage the underlying biology that exists out there in the world. So we have, over on the left, there are 19,201 coding genes in the human genome. So genes that code for, a protein. Only 4,092 of them, when we last counted, actually have a causal variation associated with them that we know cause a specific disease. Not to say there aren't like lots of variants that have modifiers, but like are causal for a disease. That's actually only 21%. There's a lot of the human genome that we don't know a lot about. When you take the orthologs, that is the same genes in 5 most commonly used species, worms, fruit flies, mouse, yeast, and we see, okay, from those same genes in those other organisms, we look at what we know about those other organisms, we have 83% coverage. We know a lot about genes from model organisms and their variation. If we combine them all, we get to 84% coverage of the human coding genome. This was the foundation of Monarch. Our conjecture is use all the data, treat patients as biological subjects, and use the biology data to help diagnose patients. And then there's a lot of details on this slide, but just the point here is just to say that there's a lot of genomics efforts that doesn't connect to phenotype data. There's a lot of phenotype data and clinical data. It doesn't connect to genomic data. But when we bring them all together and we use this biological data from the model organisms, it works best. And we've been able to show this over and over again in the Genomics England cohort, which is our partner in Monarch, because it fundamentally treats the patient as a biological subject. So we need to identify and diagnose rare disease patients faster. So I wanted to quickly move on to, am I down to really 42 seconds? Okay, we're gonna speed up. Obviously I had a lot to say. EHR data, we can actually screen for patients and get them moved along faster. National COVID Cohort Collaborative, National Clinical Cohort Collaborative is now the largest publicly available electronic health record data repository in US history. It was built for COVID, and it has nearly 30 million records. We now have enough patients that we can actually do computable phenotyping, which is basically a really complicated way of saying we're going to transform all that data into the graph, and then we can actually find rare disease patients that maybe don't yet have a diagnosis and need to be moved along further. So maybe this would have helped Michelle's husband, for example. We have a dashboard. There's lots of data. Open repository. Please join us for anyone who's techie in the audience and wants to help build screening tools for use in all electronic health record systems. This is an example. I work a lot with the Fanconi anemia community. The Monarch Initiative has a lot of data. There's a link there if you want to see an example. It's a DNA mismatch repair disorder, and these kids often don't get diagnosed early enough and they go into bone marrow failure. So it's really important that we find them sooner. And so we've been doing this computable phenotyping to find Fanconi anemia in that almost 30 million patients, and we are finding patients. Last but not least, the Global Alliance for Genomics and Health is a global effort to build standards for not just for genomic sequences, but for phenotypes. And we have a tool called, a resource called Phenopackets, which is a way of having a de-identified information. So I know there's a lot of sensitivity about sharing your data, but we have, again, we have access to genomic data and we have access to clinical data, but never shall the two meet when it comes to the informatics community being able to build tools. So the goal of Phenopackets is to allow EHRs, exchange methods, laboratories, the literature to exchange case-level information in a de-identified fashion using that same structured HPO terms and other information that can help us build better diagnostic tools and share data at scale. And it's already starting to show how we can reveal the heterogeneity of a given rare disease because we haven't historically captured that information. It's usually just in summary form. So I just wanted to say thank you. How's that? 0. But thank you to all of you. Thank you to all of the data sources and knowledge sources. Monarch would not exist if it wasn't for the incredible partnerships that we have, and there are so many people listed here, and I hope that all of you will partner with us too. So thanks very much.